Hello, I'm Dr. Petros Grivas. I'm a medical oncologist in Seattle, Fred Hutch Cancer Center, University of Washington. I'm very excited today to be together with two amazing rising stars, mentees, and people who do a great job in the field. Ali, you want to introduce yourself?
Hi, everyone. I'm Ali Khaki. I'm a clinical assistant professor at Stanford University here in California.
Ruben?
Ruben Raychaudhuri, assistant professor of medical oncology, also at Seattle, Washington, University of Washington Fred Hutchinson Cancer Center.
So we're very excited to be at ASCO GU 2025. So many data sets, impressive results from different trials. We actually have a very interesting poster that Ruben is presenting today. So we try to answer a very important question in a prospective manner regarding variant histology or histology subtypes, muscle-invasive bladder cancer. And back in the day, in 2018, Ali, when you were a fellow back in Seattle, you came to my office discussing different ideas. And, we're discussing together the challenge we have therapeutically, right, in terms of treatments. How do we treat muscle-invasive bladder cancer with histology subtypes, squamous features, granular features, micropapillary, plasmacytosarcomatoid? And we actually designed a clinical trial to answer this question. Can you tell us more about the design?
Yeah, thank you. So, as you stated, there's a lot of uncertainty. Back in 2018, there's a lot of excitement around immune checkpoint inhibitors who had just been approved in the years preceding. And so we wanted to investigate could these novel therapies that have been changing the use of the treatment of bladder cancer in the metastatic setting also be effective for our sort of muscle-invasive variant histology patients. And so we designed a small feasibility study of patients who were to receive aMVAC chemotherapy, methotrexate, vinblastine, cisplatin, and doxorubicin, in combination with pembrolizumab. And the plan was to do 4 cycles of treatment prior to surgical extirpation, the removal of the bladders. And so the study included patients who had predominant variant histology bladder cancer, and we sought out to design that study. And then after I left for Stanford, you guys were able to carry that out.
So it was fantastic because actually we went to the Vail Clinical Trial Research Workshop, and this was a clinical trial, design exercise, right?
Exactly.
You came back with a
great feedback from the workshop, and we learned a lot from some really, really great colleagues and mentors. And so put that protocol together through that training program, and then in the year after that, we were able to get that open in the middle of COVID.
Exactly.
And in the few years since then, you guys have been able to accrue and now show the result.
What a remarkable milestone, right? Shout out to ASCO and AACR for having this clinical trial workshop, and then Ruben, you went for a different trial to that workshop. So that study, as Ali pointed out, included patients with histology subtypes, muscle-invasive bladder cancer, predominant non-urothelial component or pure non-urothelial component. We had 17 patients, localized muscle-invasive bladder cancer in single center, University of Washington Fred Hutch Cancer Center, and we got the trial done, complete accrual, during the pandemic, and a little bit afterwards, and that shows the commitment. The group tried to answer this question. Ruben, you have been amazing to look at the data, clean up queries, analyze the data, and you're presenting the poster today. Tell us about the results.
Yeah, the results look very, very promising for this novel combination. So the primary endpoint was the pathologic complete response rate, and it was met. So 9 out of 17 patients achieved a pathologic complete response, meaning that there was no residual tumor after the chemotherapy. Additional patient had a downstaging, and importantly, all but 2 patients went on to get radical cystectomy, supporting that this is a very safe and feasible approach as well, consistent with the known profile of aMVAC as well as pembrolizumab separately. The 2 patients who didn't go on to get surgery, one of them had disease progression prior to going through with surgery, and the second patient actually had a clinical complete response and opted for bladder preservation, actually. So very, very promising results in a traditionally very challenging to treat population. I think some of the limitations include the heterogeneity within the patient population. So we know that not all of these patients are the same, right? But the samples, having a trial of finding 17, say, plasmacytoid patients would be very, very challenging. And so I think this gives us a lot of really compelling data about how to treat this this challenging population for whom there's been difficulty getting data for.
And I'd add that this also adds to additional data we've seen since this time of the benefit of sort of immunotherapy in the perioperative setting with the Checkmate 274 adjuvant data and the Niagara data, and also a similar variant histology trial that we had at Stanford where we used durvalumab with platinum-based chemotherapy. That trial unfortunately stopped early due to low accrual, but we were able to show a good response PCR in 2 of the 6 patients, including that study. So, in total, we're seeing that immunotherapy-based combinations are safe even for these variant histology patients. They're feasible, and allow people still to get the surgery and can have some pretty promising results.
I agree with Ali and Ruben. Great presentation of the results and, all the details, and the study you did at Stanford, similar in design. And just to reiterate, the main take-home points, we had 4 cycles of dose-dense aMVAC with growth factor support and 3 doses of pembrolizumab. And the majority of patients, Ruben, went through that therapy, right? Very few had to stop, if I remember correctly, treatment.
So very few, yeah. And when they did, I believe 4, one had to have a dose delay or a dose reduction. And then I believe 2 stopped early, but those 2 went on to also get immunotherapy. So it's consistent with what's been seen with aMVAC in the past, I would say.
Exactly. So the feasibility was there. We saw that the combination is feasible. Patients were on to get radical cystectomy, the vast majority, with no major complications. And we are very excited about the pathological complete response approaching 60%, almost. If you account the one patient had CIS only and 0, and we had an additional patient with a clinical complete response. So I think it's very exciting to see that, in a very difficult, as you point out, Ruben, population in terms of the biology and histology of disease. And the question is, where do we go next? Are we going next? And that's a big question. I think there's an opportunity, maybe cooperative groups, maybe something to consider to move that combination down the road. And as you point out, Ali, it's in the context of the Niagara trial with gemcitabine durvalumab, also the Aura trial that also looked at dose-dense aMVAC plus avelumab as part of that trial that looked very promising results. So I think we also have the upper tract neoadjuvant trial, action 8192, that will look at dose-dense aMVAC plus minus durvalumab for upper tract localized disease, and we have that trial open. So I think all the data together point out that the chemotherapy immunotherapy combinations seem feasible, and that we're going to work on biomarkers, right?
Absolutely.
Market analysis.
Yeah, so we collected plasma circulating tumor DNA at multiple time points across the study. There's in the poster today, we've also demonstrated some of the peripheral immune cell biomarkers. Unfortunately, we didn't find anything that was statistically significant in terms of T cell compartments or innate cell compartments in terms of response to therapy, but interesting nonetheless. I think part of that is because of, most patients, it's hard to correlate with EFS and overall survival when most people have not yet met that endpoint. So a lot of interesting work going on in the biomarkers, a lot of interesting work going on in the cystectomy specimens as well. So stay tuned on a subsequent data set.
Absolutely. And Ali, if I remember correctly, the Niagara trial, they allowed histology subtypes. If I remember, 15% of patients had histology subtype. About half of them were squamous.
Yeah.
So it's interesting to put this data, synthesized together, and that maybe chemotherapy, immunotherapy may be a reasonable approach in cancers.
Yeah, I agree. I think that, we, in the absence of data, I think we should still try to treat many of these patients like we knew other muscle-invasive bladder cancer patients. And I think having even small data sets like this help give us more confidence that we can still do so. And of course, the small cell was one population that we did exclude in our study and probably is quite distinct biologically. But otherwise, for other populations, I think that these clear data sets give us more confidence that still using a neoadjuvant approach can be appropriate for many of these high-risk populations.
And the vast majority of patients in our study had urothelial as a primary, but with a predominant variant histology component. And that may be a bit different than a pure squamous pure adenocarcinoma that may have a different biology. And as you pointed out, we excluded a pure neuroendocrine small cell carcinoma. Usually we do platinum metoposite from those neuroendocrine. So more work to be done, of course. There's heterogeneity, as you pointed out, in different subtypes. Heterogeneity between the urothelial with the variant histology versus pure complete non-urothelial. There may be some different biology elements there. But I think the study is very interesting. I'm excited we got it done with your help and major contributions by both of you.
Yeah, congratulations to both of you guys to finish that study. So, yeah, very exciting.
The power of teamwork. Yes.